Welcome to the deep dive. You've brought us a real powerhouse of a source today.
Yeah,
The Radiation Oncology Question Review, second edition.
it is, yeah.
This book looks like an absolute must-have for anyone serious about the field. So I think our mission today should be to, really distill its structure, the key clinical updates, and give everyone a head start on some of these really high-yield points.
Exactly. And this isn't, light reading. It's a very focused, very authoritative review. It was written by residents and expert radiation oncologists from the Cleveland Clinic Taussig Cancer Institute.
Okay.
Its whole purpose is knowledge reinforcement. It really demands that, the data cold, which is, it's crucial for boards, for maintenance of certification, or frankly, just for staying current.
Let's start with how they've structured it all. Because when you're studying something this dense, organization is, well, it's everything. How does the book take such a massive field and break it down?
It's organized very logically by treatment site.
Genitourinary, thoracic, CNS, that kind of thing.
Exactly. Genitourinary, gynecologic, lymphomas, pediatrics, you name it. And for each site, they systematically cover everything you need to know. The natural history of the disease, its epidemiology, diagnosis, staging,
The whole 9 yards.
all the way through treatment options and even managing side effects. But the key feature, I think, is the Q&A format. It forces you to actively recall information.
Right, not just passively read it.
Yes. And it links every answer, every concept, directly back to the critical citations and the pivotal trials that actually set our standard of care.
So that structures the bedrock. But, oncology changes so fast. What are the most critical updates in this second edition that made you think, okay, we have to talk about this version?
Well, the updates really reflect the biggest tectonic shifts in the field recently. The most fundamental one across the board is the full incorporation of the new AJCC 8th edition staging criteria.
Oh, okay. That's huge.
It is. If you're not using the 8th edition, you're practicing old medicine, plain and simple. This book makes sure you're current.
And staging dictates pretty much everything, prognosis, treatment approach.
Yeah.
What else has been integrated?
We're also seeing the latest data that supports the expansion of SBRT, that's stereotactic body radiation therapy,
Right.
especially in areas like thoracic and spine treatments. There are updated approaches for hypofractionation in high-volume diseases like breast and prostate cancer.
So safer treatments in fewer sessions.
That's the goal. And they also cover new advanced treatment planning techniques, and this is critical. They've added a dedicated, focused section on soft tissue sarcomas.
Which is an incredibly complex area.
Exactly. It acknowledges the specialized management those tumors require.
Okay, that gives us a great overview of the scope. To really appreciate the depth here, let's step into a couple of specific clinical scenarios. How about we start with head and neck oncology? That's an area where timing and intensity are always being debated.
Sounds good.
The book seems to really emphasize a foundational trial, RTOG 9003. Why is that one still so critical when we talk about altered fractionation?
RTG 9003 is still the gold standard because it definitively answered the question, can we do better than our standard fractionation? It compared standard RT to 3 different intensified or altered regimens for locally advanced squamous cell cancer.
What was the outcome?
What's fascinating is that 2 of those intensified regimens showed a really powerful advantage.
And what was that advantage specifically?
A significant benefit in what we call local regional control, or LRC. The 2 successful arms, one was hyperfractionated RT, and the other was accelerated RT with a concomitant boost. They both improved LRC by about 10 percentage points.
10%.
10%. We're talking about moving the control rate from around 45% with standard RT up to about 55%. And that 10% isn't just a number. For the patient, that can be the difference between local failure and a cure.
That is a huge clinical gain. For the sake of, accuracy, let's detail those schedules. What were the specific doses for those high-performing regimens?
Okay, so the hyperfractionated arm, it delivered a really high total dose, 81.6 gray, but delivered in 68 smaller fractions at 1.2 grays twice a day.
Twice a day.
Yes. And the accelerated RT arm with the boost used a dose of 72 grays in 42 fractions.
Those twice-daily regimens, they demand a lot from the patient in the clinic. What's the biggest practical challenge there, and does that LRC gain actually translate into, long-term survival?
That's the perfect question. The challenge is toxicity, it's patient compliance, and just logistics. It's a very complex, long course of treatment.
I'd imagine.
But the data supports the effort. While RT29003 itself only showed a marginal survival benefit, a later meta-analysis called MARCH really solidified the impact. It showed that hyperfractionated regimens specifically gave an 8.1% overall survival advantage at 5 years.
So yes, the intensification is worth it.
Absolutely.
And if that twice-daily schedule is just too much, I think the idea of accelerating by just adding more weekly fractions also proved effective, didn't it?
Yes, exactly. The NHANSA 67 trial provided a key practical solution for that. It showed that simply going to 6 fractions per week versus the standard 5.
Just one extra day.
Just one extra fraction per week gave a definitive advantage in local regional control and disease-free survival. The LRC was 70% in the accelerated 6-fraction arm versus 60% in the 5-fraction arm. It really established the foundation for compressing treatment time safely.
That really shifts the discussion from just the schedule to the biology.
Yeah.
Head and neck protocols now are just. They're completely dominated by the distinction between HPV-positive and HPV-negative disease.
They are.
How does the review help users clearly separate those two clinically distinct entities?
The clinical profiles are like night and day, and the book really emphasizes this because it dramatically impacts prognosis and now our de-escalation research. HPV-positive disease is typically seen in younger patients, often Caucasian men, with little or no history of smoking or heavy alcohol use.
Oh.
They tend to present with smaller primary tumors, so T1 or T2, but often have this bulky advanced nodal disease, N2 or N3, that might even look cystic on an imaging scan.
So less local tumor, more nodal spread, but generally a better prognosis. How does that contrast with the sort of classic HPV-negative profile?
The HPV-negative disease is that classic presentation you think of, linked to heavy smoking and alcohol. These patients are typically older, and they often present with advanced local disease T3 or T4 primaries.
I see.
The book makes it crystal clear. You're essentially treating 2 separate diseases, and that demands 2 separate approaches.
That's a perfect transition point. Let's move from head and neck down to the central nervous system. That's an area where precise guidance and dose algorithms are just essential. The CNS section uses trials like RTOG 0539 to establish risk stratification for meningiomas.
Right.
How does that trial simplify management decisions for those tumors?
Well, RTOG 0539 basically established the modern framework for using adjuvant radiation based on risk. It defines 3 core risk groups that determine whether a patient should just be observed or get a standard dose or even a dose-escalated therapy.
Okay, walk us through those risk tiers. This is where the specific prescription gets decided, right?
Right. The lowest risk group is pretty straightforward. Low risk. This is for patients presenting with grade 1 disease at their initial diagnosis. For these patients, observation is usually the standard of care, regardless of how much was resected.
So when does radiation become mandatory?
Intervention starts with the intermediate risk group. This includes a recurrent grade 1 tumor or a grade 2 tumor after a confirmed gross total resection, a GTR.
Okay.
For this group, the recommended adjuvant prescription is 54 gray in 30 fractions. And then finally, you have the high risk group. This is for any subtotally resected or recurrent grade 2 tumor or any grade 3 tumor at all.
And for them?
Because the risk of recurrence is so high, the recommended dose is escalated up to 60 gray in 30 fractions.
That provides a really crystal clear treatment algorithm. It's linked directly to the pathology and the surgical findings. And speaking of focused dose, the book also highlights radiosurgery, doesn't it? For smaller CNS lesions.
It does, yes,
Yeah.
especially for smaller imaging-diagnosed meningiomas where surgery might be too risky. The University of Pittsburgh published a lot of data on this. They showed for 219 patients treated with just radiosurgery, they achieved excellent local control rates.
How?
Greater than 90% control at 10 years. It really reinforces how effective that highly focused dose can be.
The CNS section must also tackle one of the most technically challenging scenarios, which is reirradiating spine metastases, especially when the spinal cord is nearby.
Oh, absolutely.
The book points to some MD Anderson data on SBRT for these cases. What does that data show us?
It shows that SBRT is a powerful tool, even for retreatments. The MD Anderson prospective study used spine radiosurgery to safely and effectively retreat spinal metastases. And the outcomes were impressive. Both the 1-year radiographic local control and the overall survival rates were 76%.
76%. In a retreatment population.
Exactly. That's a huge success rate for a patient population that often has very limited options left.
This whole deep dive really shows that this radiation oncology question review it's like a high-fidelity snapshot of modern practice, linking these complex treatments right back to the evidence.
And that linkage is so key because practice just continues to evolve at lightning speed. It's not just about memorizing facts, it's about learning the impact of new data. You know, think about the complexity added by the AJCC 8th edition for lung cancer staging.
Okay, give me an example.
A tumor that used to be a T2B-so greater than 5 centimeters but less than or equal to 7 centimeters is now classified as a T3. That stage shift changes the prognosis, and it often mandates a change in treatment modality. It proves why these updates are so essential.
And it isn't just about the tumor itself, it's also about minimizing collateral damage. The dose constraints for organs at risk, they've gotten much tighter, haven't they?
Oh, absolutely. The book emphasizes the latest dose constraints based on key safety data. For instance, the RTOG 0617 trial highlighted the severe correlation between higher doses to the heart and increased mortality in non-small cell lung cancer patients.
Right.
Specifically, they found that heart V5 and V30, that's the volume of the heart getting 5 gray and 30 gray, are significant factors driving morbidity. Understanding those specific dose constraints is the difference between safe and unsafe practice. That's the level of detail that makes this resource indispensable.
This distillation of high-yield data really confirms the value of a resource like this. It gives you critical, trial-based knowledge across so many different fields, ensuring you're applying the safest and most effective standard of care.
Precisely. And before we finish, let's just lock in that foundational head and neck knowledge we talked about earlier.
All right, give us the final review question.
Okay. You encounter a patient with locally advanced head and neck squamous cell cancer. They're being considered for definitive radiation alone. Based on the RTOG 9003 trial findings, what specific dose and fractionation schedule offers a significant improvement in local control over standard fractionation, and by roughly what percentage?
That's the critical piece of information that really drives clinical decision-making. Thank you for guiding us through this essential review material and helping us complete this deep dive.